There needs to be a willingness. The treatment for personality disorders is therapy. We do know in those that engage in treatment and go through the process, in 10 years, 82% of people with borderline personality disorder will no longer meet the criteria. So actually, if you look from like a prognostic standpoint, it's one of the best prognostically diagnoses you can get in psychiatry. And historically speaking, if you go back 20 or 30 years, people thought it was lifelong.
You're listening to Conscious Mind.
Hi, everyone. Welcome back to the show. I am Molly Norton, and I am joined today by Dr. Ryan Flanagan. He is the director of the Resilience Program at River House here at Silver Hill Hospital. From what I understand, Dr. Flanagan, you were an employee here actually many years ago before you came back to work as a physician here. Can you tell me a bit about that?
Yeah, of course. I was. So I graduated college in 2010. I had no idea what I wanted to do with my life. I knew I kind of wanted to work in the mental health field, and I'm somewhat local to the area, and this was the psychiatric hospital that people sort of knew about. And so I applied here to work as a psychiatric technician / residential counselor. At that time, you sort of did both. And at that time, I worked in the ACU and Scavetta, which was the men's house, I believe. Mm-hmm. I was only here for 6 months. We can talk more about sort of my journey here. But yes, I was here for a very brief period in 2011-ish, and I do remember some people.
Interesting. I started here in 2013, and I think it was 2013. And I don't remember you, so you were not here at that time.
I was long gone.
Long gone.
Yeah.
Okay. But funny enough, I grew up in this area too, and I know exactly what you mean when you say like this was the place in the area, right? If you grow up in Fairfield County, Silver Hill has always been a name that you're aware of.
Of course,
whether you're in the field or not.
Yeah.
I think it's just kind of a local.
Absolutely.
It's been here a long time. So tell me a little bit more about your path to becoming a psychiatrist. So
sure.
What led you in this direction into this field?
Yeah. For me, I kind of trace it back to college. I didn't know what I wanted to do when I first got to college. I come from a family of people who are kind of in business, and I have 3 brothers, and they're all in finance and marketing, these sorts of things. And I knew I didn't want to do that. But I was struggling to kind of find my path. And then I took an abnormal psychology course, maybe it was junior year, and it was fascinating to me. I specifically remember learning about schizophrenia, the idea of people having like auditory, visual, and sometimes like olfactory hallucinations, smelling things, seeing, hearing people that aren't there. And that was like totally fascinating to me, and that kind of started the journey. And so, many, 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 many years later, I'm now a psychiatrist back at Silver Hill.
Awesome. Where did you go to school?
I did undergraduate at Gettysburg College in Pennsylvania, graduated in 2010. Then I worked here at Silver Hill for that 6-month period. I don't want to say this, I didn't love my job as a psych tech, but I know I wanted to still work in the field, so I decided to go to medical school. At that point, I hadn't taken any of the pre-med courses, so I did a program, it's called a post-bac program that a lot of doctors do, where it's you graduate from college, you hadn't done the pre-med courses, but you want to go to medical school. And so it's like a 1 to 2 year intensive program. I did that at NYU. And then I applied to medical school, and I went to Georgetown for medical school in D.C.
Amazing. The psych tech job is the hardest job in the hospital. I'll stand by that for the rest of time. I actually did it for a minute myself, and I would come home crying at the end of the day just because it's so hard, and it's so heavy, and it's a 12-hour shift, and you're with people at their darkest times, and you're with them, within arm's reach a lot of the time, and that can be really challenging.
Yeah, absolutely. I mean, you're the principal point of contact, and you're often, my job now as the doctors, I make a decision, I tell the patients, and then I have to leave, and I'm going to another meeting or meeting with somebody else, and I'm not necessarily there to deal with the fallout. That's like the psych tech or the residential counselor, and so they're the ones dealing with these issues in the moment, and it's exhausting. It's emotionally exhausting.
Really,
it takes a special type of person to
do
that.
And it's interesting that it's an entry-level position for a lot of people that, like, in our field. In what other field or other business do they throw people right into the most challenging role to kind of see if you could get your sea legs, I guess, and if you can, manage this type of work? It's exceptionally hard. But now you're back here and you're working in our resilience, newly branded resilience program. Many people know it as River House, or what was formerly our DBT, dialectical behavior therapy program. And, the name may have changed, but I think the folks that tend to come to get treatment in this program, have struggled with emotion regulation, oftentimes have a diagnosis of borderline personality disorder. And that's one of those psychiatric conditions that I think is misunderstood. A lot of psychiatric conditions are misunderstood, but borderline personality disorder, I think, sometimes gets a reputation, I want to say.
Yeah, absolutely. There's a stigma.
There's a stigma, right? Can you talk to us a little bit about, given that you've worked with so many people with this condition, what do you know about it that our listeners might not?
Yeah, I mean, I think the idea of personality disorder and even the term for personality disorder, I don't like that term, and my hope is sometime down the road, I don't know how many years, that we kind of do away with personality disorders as a construct. But generally speaking, this is how I try to explain it to parents. We're all born with a temperament. It's biological. We get it from mom and dad. We have absolutely no say over what our temperament is, right? You have kids, you know that your child was colicky or a happy baby or whatever, XYZ. Throughout early development, we have these different influences on ourselves, right? We have psychological, social, environmental influences that all kind of occur, interact with that temperament, and form kind of your personality structure, what your personality is. Depending on all those factors, you can have adaptive personality traits or you can have maladaptive personality traits that just don't really work for you. If you have enough of those, then you can kind of meet criteria, get into the threshold for being diagnosed with personality disorder. There are three main clusters of personality disorder. There's cluster A, B, C. The resilience program at River House, typically we treat cluster B. These are typically individuals who have issues with interpersonal relationship difficulties, emotion regulation. I think one of the things that I want to convey, personality disorders are different than mood disorders or anxiety disorders, right? Personality disorders, it's in the name, it's pervasive, it happens. It's how you interact with the world and others and in certain situations and circumstances. Mood disorders typically are episodic. You're depressed and then you go back to baseline, or you're manic or hypomanic and you come back to baseline. And so personality disorders are a much more pervasive way of being and existing in the world. And a lot of people don't know that.
So where my mind goes is, if we don't call it personality disorder, what else could we call? Given that it is something that's pervasive and it has to do with how we interact with the world, how can we reframe it in a way?
And I think the DSM, which is the Diagnostic and Statistic Manual for Psychiatry, the last one, the DSM-5 came out, and the back of it, they have things for consideration. I forget exactly how it's framed. And one of them is this alternative model for personality disorders. And we've actually started to incorporate that at River House. It is a dimensional as opposed to a categorical-based approach. Okay, so we're not necessarily putting you in this big, broad category of borderline personality disorder, antisocial or histrionic personality disorder. We are looking at domains of functioning and sort of assessing those domains, which allow us to have a much more targeted sort of treatment for the individual, and we can actually measure outcomes much better. We've worked with a clinical psychologist, Dr. Kessel at River House, who's found us a lot of really great screening items and scales that we're using, and we can actually track these domains of functioning. The domains include negative affectivity, detachment, antagonism, disinhibition, and psychoticism. So these are all things that individuals with personality disorders can have a degree of sort of adaptive traits in or maladaptive traits in.
So is it like a scale of 1 to 10?
Kind of. It can be thought of that. Yeah. And is it a problem for you? Is it not a problem for you? How sort of extreme on the scale do you fall? And based on those answers, we can kind of try to tailor treatment. Because if you think about borderline personality disorder, in order to meet criteria, you need to meet 5 of 9 symptoms. And if you do the math, and I didn't do this math, I Googled it, but there's 256 different ways
combinations, right?
Of being borderline personality, of meeting that criteria.
Heterogeneous, as they would
absolutely.
say.
And so it's you put somebody in this category, and in reality, they can look like 256 different ways.
Different
and so
people.
kind of shifting this to a more domain-based approach, I think is going to be super beneficial from a clinical perspective, but also in the future with the research and stuff like that. It's going to provide a lot of unique opportunities.
Tailor the treatment to that individual instead of putting everybody in the same box.
Yeah.
Yeah, it is. It's fascinating. I remember learning about that, is all the different combinations for these things. And, for some people, it's helpful to have a diagnosis and they can connect to that and they find, ways of that being helpful to them and just kind of knowing that they belong somewhere. But when you have that many different combinations, how do you really focus in on what's a problem for that person?
Absolutely. And I think some people have an idea of if you have borderline personality disorder, you will look or present a certain way. And that's not the case. There are a ton of different presentations and responses to treatment and ways that treatment can go. Just that category alone is not enough to predict that.
What do you see in treating people that have a borderline personality disorder diagnosis? Is there a certain kind of type of symptom pattern that tends to respond better to treatment? Is there a characteristic that people share that do well in treatment?
Yeah, it's a good question. I think a couple things come to mind. One, especially with personality disorders, there needs to be a willingness. The treatment for personality disorders is therapy. We can give medications to help treat symptoms. It's analogous to giving Tylenol if you have the flu to treat a fever, right? You're not actually treating the flu infection, but you're just treating a symptom of it. We can do that, but it's not getting to the root of the issue. And so PD or personality disorder treatment is intensive therapy. And so you get out of it what you put into it, right? So we need motivated individuals. If you are not willing to work on it, you're probably not going to get better. We do know in those that kind of engage in treatment and go through the process, in 10 years, 82% of people with borderline personality disorder will no longer meet the criteria.
Really?
So actually, if you look from like a prognostic standpoint, it's one of the best prognostically diagnoses you can get in psychiatry.
Wow.
Historically speaking, if you go back 20 or 30 years, people thought it was like a death sentence.
No,
it
and
was
that's
lifelong.
huge. And I think with the stigma that we talked about before, so many people would say, oh no, I have borderline personality disorder, or, people refer to me as borderline, and it has that negative connotation, but because it's not like the mood disorders that may have more of like a biological, and I know that gets complicated when you talk about biological.
No, we can talk about that. It's interesting
because
though.
it could all be biological, right? But if there's not that like need to necessarily treat the underlying disorder with a medication, and a big piece of getting better is just willingness to work on it and try.
Yeah.
That's hopeful.
Yeah, no, and one of the kind of the core issues that kind of often bring together most of the individuals with BPD is this idea that it's related to interpersonal or relationship struggles. There's typically some form of dysregulation that occurs in interpersonal relationships. That is often a defining feature of these individuals. And so the work is not typically just individual, right? You have to involve family members, support systems. We've incorporated something at River House called GPM, or Good Psychiatric Management. And this was developed at Gunderson and Harvard by Dr. Gunderson. And it is looking at very practical psychoeducational, situational approaches to this. The main focus is interpersonal hypersensitivity. So how do we navigate these situations in a way that kind of just like makes sense?
So I'm going to do this.
Yeah.
So I'm your patient, and I come to you and I say, my husband said something to me, and I had an extreme reaction and screamed at him and cried and said I'm leaving and stormed out of the house.
Yeah.
You said it's good psychiatric?
Well, good psychiatric management.
What
actually,
what would you tell me to do?
I would tell you, I actually wouldn't use something from GPM. I'd use something from one of the other modalities we use at River, MBT, which mentalization-based therapy. And, the core of that is that people who have cluster B personality disorders often struggle mentalizing. They don't understand their own internal thoughts, feelings, and those of others. And so in that instance, what I would try to do is kind of have you replay that situation and put yourself in the mind of your significant other. What were they thinking? Why were they thinking that? How did they respond to XYZ action of yours? To get you to mentalize them. And we know that if you are able to mentalize both yourself and others repeatedly, it can help with the interpersonal relationship issues that we see in borderline.
Mentalization is a really fascinating subject for that exact reason, because you would think that people just do that automatically, but they really don't.
Yeah.
like not everyone has that ability to or willingness to just put themselves in another person's shoes and take another perspective of another person. So teaching that it seems like the simplest thing, right? Like, oh, just think about how the other person sees it. But we don't do that automatically.
No, you're absolutely right. And there are like different ways that you can mentalize either correctly or incorrectly. And the whole premise of mentalization-based therapy is figuring out what type of incorrect mentalizing is that patient doing, and trying to kind of push them to the other pole. And it's like a workout. It's repetition. You keep doing it, you keep doing it, you keep doing it, and eventually they will develop the skills. And it actually makes a huge difference. There are tons of literature and how effective it is for the treatment of BPD.
Wow. So the brain is truly a muscle that if you exercise the muscle enough times, it will start to
changes.
To change.
Those synapses, and I know we talked about the biology of BPD. We are learning more about the biology of BPD too, which is really interesting. And it hasn't translated to any real treatment options just yet, but we know that there are certain like neuropeptides that are involved. Opioid, oxytocin, vasopressin, these sorts of things are abnormal and can be abnormal in those who have BPD. And we've actually been able to correlate those abnormalities to types of symptoms. We just don't have treatment approaches yet. And so it's an exciting time to be kind of in the field, because hopefully that's coming. Right,
and we're getting more precise in how we treat things. Going back to the good, is it good psychiatric,
good psychiatric management?
So what's an example of something you would, how would you educate a patient about that?
Yeah, so it's funny. One of the principles of GPM, or good psychiatric management, is psychoeducation. So it's not just psychoeducation to the patient, but also the family. So disclosing the diagnosis is a big part of this, right? I think we've talked about the stigma of BPD and how sometimes providers were historically not sort of willing or felt comfortable with telling somebody they had a personality disorder. Actually, a really important part of the treatment. And there have been studies that have shown that just diagnosis disclosure actually can help improve symptoms. So we do that. We also focus, and at River House we do a monthly family psychoeducational seminar where I talk about BPD, mood disorders, and sort of the interplay between the both and how you treat them. GPM focuses on something called situational pragmatism. It is one of my favorite sort of convoluted terms for just describing an approach where you just kind of do what makes sense and is rational kind of in the moment. You meet these patients where they're at, and you make an informed decision based on treatment or discharge or medications or whatever, based on what they can do at that time. You don't throw too much on them. You be pragmatic about it.
Right. Again, it's like the common thread here is using common sense, but in a directed way to help people, behave and think from that standpoint of like kind of even-mindedness. And it's interesting. And I think DBT, dialectical behavior therapy, which is what, for years and years has been kind of the lead treatment modality for personality disorders, has a lot of those components as well. What do you think has been, in your experience with DBT, what elements, as your program changes, and clearly there's like new treatments that are coming out, and it used to be only DBT was really the primary way to treat these things. What do you hope to kind of hold on to when it comes to dialectical behavior? What's been the most effective?
Yeah, of course. Listen, and what I'll say is we've transitioned to the resilience program, and it's a multimodal program now, but DBT is still the core of the treatment there. So I really haven't changed the DBT program because that is still considered the gold standard, right? We are incorporating MBT as a way to sort of shore up or help with the underlying DBT skills training that they're receiving. And so, I think it's funny, River House, we typically treat this young adult college-age population. I think the most beneficial historically to these people have been sort of emotion regulation and distress tolerance. Those are the two kind of skills that people tend to find the most use out of. However, interpersonal relationship and mindfulness, these are also very, very important, and especially when it comes to trying to apply these sort of mentalization-based techniques that we're trying to teach them as well. You need to be mindful. You need to have some interpersonal skills. So it all kind of, in my perspective, fits in really nicely and works well together. And they don't antagonize each other
Right.
at all. It's like
It's
a seamless.
complementary.
Yeah.
Yeah. It's great. And it's great that there's not just one tool in the toolkit for treating these folks.
Yeah.
Speaking of these people, and as you said, there's many of them that have many different symptoms. Is there any sort of like, from a strengths-based approach, so things that you've noticed that, wow, a lot of these people that I treat tend to be really good at this one thing, or they have something in common that they share that's actually a kind of a hopeful thread that connects them. I mean, when I specialized in treating OCD, and something I noticed was like, these people are so kind and nice.
Yeah.
And they have, horrible anxiety and horrible symptoms that really debilitate them, but like, they're all just really genuinely like kind and good people.
Yeah.
Obviously, borderline personality disorder is a lot different from OCD,
Sure.
but like, is there a creativity or any sort of element that you've noticed?
Yeah, listen, I think creativity is a big part of it. I mean, we treat people who are absolutely brilliant. They're brilliant. They're creative. They're highly successful people in kind of whatever they choose to do, and this sort of disorder has really gotten in the way of them functioning to their best ability. I think you have this idea of like people with personality disorders and they struggle with relationship issues, which is certainly true, but it's not pervasive across every single relationship that they have, right? There are typically relationships that are triggers for these people. So it's not like you're going to like walk up to one of them and talk to them and can't have a normal conversation. That's not the case. I developed really strong therapeutic relationships with most of my patients, and they're great to work with. They're really collaborative. They're nice. They're friendly. They're funny. They're just like totally normal people who are struggling.
Right.
They feel emotions very strongly, much more strongly than you or I feel them. And they don't have the skills to regulate. They go from that 0 to 100 in a second.
Yep.
Whereas you or I or somebody who doesn't have a personality disorder can take a step back and kind of regulate. They don't have that.
Right.
And we know that that's due to biology. It's due to psychological influences. It's due to their underlying temperament. It's due to all these different things that aren't a fault of their own,
Yeah. No, the temperament, the biological element of childhood plus, the formative experiences that they have and I'm going to get a little personal. So as a parent, how in knowing all of this, and I think about this stuff all the time because I think about my kids and I have one that's more sensitive than the other. I'm always thinking about how do I not like invalidate her and make sure that she develops these healthy coping skills with the inevitable challenges of life, right?
Yeah.
So how do you kind of, knowing what you know, how does that translate into like parenting?
It's a good question, right? I mean, I'm a parent to 2 young kids too, and I think one of the things that I've learned, you can't pathologize kids' behavior.
Right.
Part of it is just part of the normal developmental process. I'll say if you go to the DSM right now and you look at the diagnostic criteria for borderline personality disorder and you take any toddler off the street, they all meet 9 out of 9 criteria for BPD. Doesn't mean they have BPD, right? That's right. You can't diagnose it until you're 18 at least.
That's an interesting fact that many people might not know is that it doesn't get diagnosed until you're out of childhood.
You have to be an adult.
Yeah.
Because it is, some of those symptoms, the relationship issues, the hypersensitivity, the unstable sense of self, loneliness, these things are part of the normal developmental path of children. And I would say for parents out there, don't read too much into this behavior, right? I mean, certainly if it becomes a major problem and it's functionally impairing, yes, go see somebody. But if your child is more sensitive or struggles with certain things, X, Y, Z, and they're at that age where it's kind of part of the norm, ride it out a little bit. You know what I mean?
I get stuck on the validation thing of like, oh, your kid gets hurt.
Yeah.
And your natural response is like, you're fine, you're fine, right? Because you need to be fine as the parent.
Sure.
But actually, the literature might say, like, validate the experience of the child, right? Like, I see that you're hurt. I understand that you're hurt. What can I do to make it better or help or whatever? But then, like, in reality, you have a kid who didn't actually get hurt is screaming like they've been cut open.
Yeah.
And how do you
No,
how do you act
when
right?
you find out an answer to that, you let me know, because I'm dealing with the same thing and I don't exactly know what to do.
Right,
But
exactly.
I typically just ask my wife to,
Yeah.
to talk
So,
to them.
talk to the kid. I don't know what to tell her. Yeah. It's like you don't want them to be unable to face the world, and you want them to develop some sort of like thicker skin, right?
Absolutely.
But you also don't want to make them feel like
Yeah.
they can't trust their own internal experience.
Yeah, I don't think you can go wrong with validating an emotion or experience. I think that's fine. You
Okay.
know, stick to that.
We'll put that. That's for the record. Everyone who's listening. So you can't do it wrong. I mean, there is such thing as like good enough parenting, right?
Sure,
That's
yeah.
like you don't have to be the best of the best to raise a healthy child.
Absolutely not.
Like, what does progress look like? We can.
Yeah.
You want to maybe pick that back up and ask.
Okay.
Sure. So we've talked a lot about borderline personality disorder, and in treating borderline personality. Starting over. So we've talked a lot about borderline personality disorder. How do you know if someone's getting better? How do you know if the treatment is sticking, if the concepts are working?
Yeah, I mean, you know, in thinking about DBT, if you look at the DBT skills, they're not super difficult to understand or learn, but the implementation is hard. And so, you know, at Silver Hill, we obviously work on the learning aspect of the treatment here. We want them to learn these skills, and then we try to create sort of situations and environments where they can implement them, right? Whether it be a phone call with parents, or they go out on a day pass, or these things where they're experiencing these stressors and they're able to kind of work through and use these skills in a way that are effective. What it looks like when somebody gets better, I think it just comes down to functioning, right? Like, it's not necessarily one of these things where a light switch goes off and you're like, oh my gosh, I'm 180 degrees better. It's one of these things with like the benefit of hindsight. You might look back in the last 6 months and be like, you know what? I've been in my job for the last 6 months and I've had no problems and it's going well. And I've been with my girlfriend and yeah, we have like kind of normal fights, but nothing gets out of control and there's been no self-harm. And it's sort of one of those things, you know? I would say, you know, if you're struggling with BPD or know somebody, it's look to the relationships and look to the level of functioning.
Right.
And that will kind of help guide.
Like the health of your relationships
Yeah.
with the people probably that you're the closest with,
Yeah,
right? Because those tend to be the people that see the most of us anyway.
Yeah.
So if I were a newly diagnosed person with borderline personality disorder, what might you tell me in our first session to help me to feel better about my diagnosis and my prognosis?
If you put in the work, 82% of people after 10 years no longer have the diagnosis. And once you no longer meet criteria for the diagnosis, it's only like 10% will ever have a relapse. So it's one of these things where once it gets better, it typically stays better. And we have multiple evidence-based treatments for it. So that's what I tell them.
Wow. So hope,
Yes,
really.
absolutely.
Well, thank you, Dr. Flanagan. This has been a really, really interesting conversation, and I think an important one. And I think it's really critical for people to understand, as friends, loved ones, we all have someone in our life who may struggle with emotion regulation and some of these other symptoms, and to know that there is good help and that people do get better is extremely hopeful. So thank you.
Thank you.
You've been listening to Conscious Mind on Silver Hill Radio.